Scalpel? Check. Hammer? Check. Vibes? Always sterile. Welcome to Scrub. Alrighty, welcome everyone to the Scrubbed podcast. Our guest today needs no introduction, but I am going to introduce him anyway. This is Dr. Roy Sanders, who is a phenomenal trauma surgeon who also does extremely complex lower extremity reconstruction. He has truly done everything from implant design to leading Florida Orthopedic Institute, which is a major orthopedics group in Florida, as well as the chair and head of orthopedics at the University of South Florida. So that is just a minor fraction of the things that he's done, but hopefully we can learn more about that today alongside my co-pilot here, Miss Kinley Hatch.
Thank you for having
How you,
me, as always.
how you doing today, Kinley?
Doing great, ready to learn about Dr. Sanders. He has an interesting story that I can't wait to learn from.
Heck yeah. So Dr. Sanders, thank you for joining us. How you doing today?
I'm doing great. Thank you for having me.
You had some decent weather in Florida?
Yeah, it's now it's about 65 degrees. It gets colder in the mornings. It gets way down to 55. Woo.
Oof.
By May, it's about 70, 72. It's perfect now. It's the best time of year to be in Florida.
So I've always wanted to ask this question to another orthopedic surgeon who particularly practices in Florida. So I'll ask you better now than ever. Do you find that patients' joint issues fluctuate seasonally? And if so, does that change the way that you find them kind of complaining or rehabbing throughout different times of the season, or is that just a non-issue because of the Florida weather?
Well, when it gets down to 55, everybody puts on their winter coats. And they put on over the knee boots and try to take everything out of their closet so that they can use stuff from up north that they never use, right? But what we have here is difference in our population because of the snowbirds. So the summer's very hot. It's a lower volume of patients. And then in the fall, it starts picking up with the retirees coming down from the Midwest and some from Canada. And then around Christmas time, everybody goes back home. So the volumes of trauma decrease a little bit. And then after the January holiday season is over, we get this mass influx of people. Sometimes it triples our population from the Midwest and Canada all the way to May, to Memorial Day. And so we have reverse seasons from the north in terms of trauma. And they come down here to get their knees done and hips done in the winter because it's too cold up there. And they like to rehab here. So that works out pretty well for us because when you're a fellow up north, you start your fellowship, you get this boom, and then it's winter, and then the volumes are very low. Where here, you build up your chops as you keep going through your fellowship because the population keeps increasing and it gets busier and busier and busier as you get more and more comfortable with your skill set. So personally, I think it's really a good mix for a fellowship, but that's an aside.
Yeah, super cool. With your practice in particular, are you at the point where you're just obviously so well known that you don't see practice fluctuations? You're kind of always that steady clinic volume that you want to do, or do you find it still fluctuating with time and season?
Well, let me put it this way. For about 20 years, I would see about 200 patients a week, 100 patients on a Tuesday and 100 patients on a Thursday. Now I see and then I would book maybe 5 elective cases. Some of it, because I did trauma, a lot of it was just follow up from the emergency rooms. Now I only do elective stuff. I'm not taking trauma call anymore. And I don't know, I see about 30, 40 patients on a Wednesday, and I book 10 to 12 cases a day, every day that I go to clinic. So my yield is insane. And I imagine it's because people just want me now to operate on them, which is kind of nice after a long career that people actually understand your skill set. But it takes a long, long time to do that because you may have a national or international reputation, but all things are local. And so if you're famous nationally, but nobody knows you locally, you're going to sit around twiddling your thumbs waiting for patients, right?
Yeah, I always found that fascinating. That concept in and of itself to me is fascinating, right? So I was working with, Ned Amendola, who to me at Duke is the godfather of orthopedics. And you would see these people come in off the street, or just come in locally and not really know his reputation. So it'd be these thing where like this man that like I revere is just getting like grilled about like size of incision or like something so dumb. And it's so weird being a fly on the wall in that room.
It's a problem in general with medicine in America, right? Nobody really knows how to navigate the system. And unless you are in the medical field, you don't know who to call, who to talk to, you don't know who to go to for the issue you have. You might go to a really good guy, but he's not interested in your problem. And so then you start getting shuttled around. It's not like you can really research that well. And the internet better allowing people to have depth, but there's a lot of slop on the internet, and so it's very difficult to actually understand if you're not in medicine what you're reading and what it means. And there's a lot of self-promotion as well, and so it's still very difficult. So I can imagine Ned sitting there patiently dealing with a local patient who doesn't know his skill set, right?
Well, I think
Yeah,
it's such a testimony that I always make the joke of, okay, I went up in my attic to get my Christmas decorations. Well, I knew Dr. Bokshan was on call, so I was like, well, I'm in good hands, so I know that. But not that there's bad surgeons, but it's just knowing that background of like, oh, who's on hand call, who's on trauma call, who's on all of this to be like, am I going to do something stupid today? Not everyone has that knowledge and background information.
The other problem is that the people that are really good might be at one facility, but emergency room, the emergency vehicles might take you to another hospital, right? To the nearest facility, right? And then if you don't know, like you have to tell them, Ta- they have bumper stickers that say, "Take me to Tampa General," which is great for me because we run that trauma center. So.
yeah. I mean, even my wife was bringing this up just yesterday. Exactly the point you guys are making. She was saying something to the effect of like, why isn't there a nurse or something whose job it is to kind of just help people navigate through the healthcare system? Because I completely agree with you guys. From the moment you break a bone to the moment you find the surgeon who's going to fix it, it's like an atom just bouncing here and like finding a place to land. I just find that fascinating.
But you can imagine that if somebody is a middleman and shuttling people around, that at some point it's going to become a financial benefit for a surgeon or primary care or whatever to spend a little more money on that service so that they have preferential treatment. Again, whether they're the right mix or not, it then becomes cloudy, right? So it's still a big problem. It's still a big problem.
Well, and the internet doesn't help either. I know Dr. Bokshan's listed, I think, as a joint specialist, but you don't do total knees or total hips, so it's a little when
Oh
people are
yeah,
going thinking he's a generalist and he's like, "Nope,
or
but I know a
or
guy."
back specialist.
Yeah.
So, Dr. Sanders, would you say that many of the patients that you get are kind of familiar with your body of work, or at least they have a problem that's kind of, quote unquote, in your wheelhouse? Or are yeah, at this point in your practice, are you still getting some of those back pains or upper extremity
Oh,
traumas?
no. I screen my patients now. My secretary screens my patients, but our scheduling is pretty good. So I only see lower extremity problems, and I used to see everything in the foot and ankle just because I would see a lot of stuff. But now I limit it to ankle problems really, but people still come in with the midfoot and hindfoot problems. They don't understand that it's not technically the ankle or the lower extremity, but so I treat all that, honestly, tibia down to hindfoot, midfoot. But I don't do bunions and hammer toes anymore. I can't stand interest.
So, with you being the head of Florida Orthopedic Institute, right? Like, I definitely want to pick your brain about some questions, because I think as part of this show, I think it would be a nice opportunity, Kinley, for us to kind of explore kind of complex practice management. Some of the stuff that I really honestly, I don't think any other podcast or people are really talking about. Dr. Sanders, how many docs, or yeah, let's start with that. Providers, let's say that. How many providers do you have in your group?
So that's a complicated question. So we started Florida Orthopedic in Tampa. And I'll give you a brief little history there. So I was recruited in 1987 to come to Tampa because Jeff Mast had left. And for the people that don't know, he is one of the legends in orthopedic trauma. And I was a young guy, and they recruited me to the university. And there were 16 of us at the university, and we had a chairman named Phil Spiegel, who was a legend at the time and a big deal in the AO as well. And we got a new dean, and we were going to build a musculoskeletal institute, and the dean decided to cancel the project after the department had spent over $500,000 arranging that. So my chairman got in the dean's face a little too much, and they fired him. At which my vice chairman made us all quit in protest and form Florida Orthopedic Institute. So it was the largest mass resignation in the history of higher education in the United States at the time. That was in '89. And they brought in a new chairman, and then the courts reinstated Dr. Spiegel. So there were two chairmen, and we were working at Tampa General because it had open staff, so the university couldn't really deal with us. And there were still residents in the program, and so the university's solution was to terminate the residency program. So that created a real problem. We got a second residency program through the university, but then 2 years later, the university pulled the affiliation for the hospital-based residency program. So we lost the second residency program. So after that happened, we started using fellows and a lot of APPs and mid-levels to help us. And that's how we kind of built our reputation. But the thing we did that stood out was everybody was fellowship trained. And at that time, nobody in my community other than us were fellowship trained. And so when you know what you're doing and you're only doing what you're really good at, then your results are much improved. I mean, the efficiencies are profound. And so we started to gain traction. Plus, we have nationally recognized guys. One of my residents that we were able to hire back was Mark Frankel, who basically developed the reverse shoulder. He didn't invent it, but he popularized it and really made it a ubiquitous procedure. And Dr. Bernasic, who designed tons of hips and knees for Depew and J&J, myself and Dr. Walling and others. And anyway, we were then recently, I don't know, maybe 10, 15 years ago, we started a residency again, and I ultimately became the chairman. But we were a fairly large group in Tampa, and we had maybe 35 guys. And at that point, there were problems again with medicine in America. We started, even though we were the largest group in Hillsborough County, which is the Tampa area, and we had most of the volume, orthopedic volume, we're just a small group, the 35-man group. And we could not deal with the universities and with the insurance companies and the hospital systems being that small. And so we ended up going a different route. So we brought in some management that had national presence, and we were still independent. We funded everything ourselves. We merged the groups in St. Pete and Clearwater. So we went from 35 to about 65 guys overnight. And then
Nice.
we added people. So after a couple of years, we're about 100. And then we brought in some more people and some more money for minority interests, where we were able to bring in Tallahassee Orthopedic Clinic, and we opened up clinics in Gainesville, Ocala, and Lakeland, and throughout the region. And so now we're 187 guys. We have 44 offices, 10 surgery centers, and we still own it. We're privately held. The majority ownership is all the docs, and we're fiercely independent. And so when you ask me how many docs I have, my group in Tampa is now 52 guys, girls, everything, orthopedic surgeons, and we're a vertically integrated group across Florida. We go all the way out to the Panhandle, and we're just about to do something on the East Coast. And we do, physical therapy. We do all the diagnostics. We have surgery centers. We work at all the area hospitals. We cover all aspects of orthopedic surgery. We do durable medical. We do pain management. And we have neurosurgeons as well as orthopedic surgeons for spine. And we still run fellowships and have tons of mid-levels as well. It's a really wonderful deal right now. So
Yeah.
helped us.
Yeah, you've touched on so many profound things that I think we should you know, double click on a little bit because, in your career, clearly you've created something extremely special. And part of the podcast, I hope, is that we can kind of unravel like the years and years and years of tremendous work that you've done. And obviously people see it now in all its glory, but what was it like early on when you'd say, you were a smaller group, I think 35 is massive to me, but a smaller group, negotiating with insurance companies, worrying about overhead. Like at that point, was kind of the burdens of private practice becoming too great that the concept was, hey, we need to hire a management company to kind of become too big to fail? Or like what was going through your head at that time?
Well, it wasn't that so much as, I remember the time before Hillary Care was starting and HMOs was starting. So we had a pretty nice practice that way because when HMOs started, then it was a race to the bottom, and we really didn't want to take those contracts. And so we negotiated them. We're able to do very well because we wouldn't accept those. And we were large enough that we didn't have to accept them. And that went well for a while. And we were in all the hospitals in town doing elective work and helping with the trauma call. And then after Obamacare, I guess, what the hospitals started to do, and something happened in Florida, and I forget exactly the timing, but it was about the same couple of years where, in order for the surgery centers to get 24-hour stay, the governor approved that, but at the same time, he got rid of the certificate of need. So there became these hospital systems that started buying hospitals, growing their systems, and then putting hospitals everywhere. So in order to support that, the hospitals started hiring their own docs. And when you work for a hospital system, right, you get based on RVUs and you get paid. You don't really pay overhead. And um, many of these hospital systems aren't even billing the insurance companies for the physicians time because it's just not worth it to them financially to staff everything to run the bills. So they make so much on the facility fees that they just pay the physicians out of that profit. And that's very hard to compete with, right? So they give a guy a high salary and he has no overhead. And then he has to do a certain number of RVUs and then he can, get into bonus. Whereas uh, we have to work really hard. It's piecework, honestly. The more you do, the more you make. And then you put that in, you get denied. You have to argue with the insurance companies back and forth. Denial management and revenue cycle is a huge component to our practice. And then you have to pay overhead. And then you have to pay staff and you have to pay raises and, you have to make sure you pay the electric bill and everything. So that cuts in. So one of the things that we were able to do to neutralize that is to develop surgery centers where the docs are the owners of the surgery centers, and that the distributions out of that, because we get the facility fee, also helps to defray some of the costs. And that really is a unique situation because that puts the level of income at or better in many cases than the folks working for hospital systems, but you have all the freedom of running your own practice and not being forced into what the administration of the hospital expects from you. So that's kind of where it's morphed now. And I think in the interim, though, when the hospital started hiring all these people, it became a very scary time for private practice because they were trying to kill private practice because you got to understand the insurance companies in the end, they just want to write one check. They don't want to write 1,000 checks to individual docs. And because it increases the amount of staffing they have to do. And it just, for them, it's all about margin. The insurance companies don't actually pay you when you're due. They have a certain amount of money budgeted to release, let's say, to orthopedics or ENT per month. And when they hit that, then they just won't pay you. They'll pay you the next month. They'll roll it over. Whereas we live, on a day-to-day basis. So if you do it with a hospital who has, such a big system, it doesn't really affect them. And so the insurance companies, just from a practical point of view, I don't think there's a conspiracy, but from a practical point of view, they want a simpler system so they can lower their costs. And so they just want to go to the hospitals, and the hospitals, of course, just want to control everything. So that's kind of the dynamic that goes on. So at 35 guys, it's good to cover my county, but not good enough to compete with what was going on nationally, and that's why we grew.
Yeah. And to unravel something a little bit, you made a subtle point there. The facility fee being so important to a hospital, is it fair to say that obviously a hospital surgery or a hospital OR, the facility fee is going to reimburse higher than a truly outpatient ASC?
Six
Maybe
times.
yeah,
So
but
the
unpack
problem
that.
now, if you look at what the bills that are going through Congress, right? So with a big, beautiful bill, one of the things they wanted to do was level site of service so that it wouldn't matter. And, it's really interesting. The hospitals at first didn't want the outpatient stuff in the hospital because they made money on the beds. But now they realize if you do an outpatient procedure at the hospital, they still get the same amount of money for the procedure, but they actually can then have more beds available for sick patients. So then they still can fill the hospital and still do the surgery, whereas before we used to admit everybody. So it's somewhere between 4 and 6x. I don't know, in the end, that's the bill, but that's not what they negotiate with the insurance companies, and every hospital is different. But it's substantially higher than what the insurance companies will reimburse us in the surgery center. And so there are senators that are trying to push a leveling of the site of service, but that would probably kill the vast majority of hospitals in the United States because they can't afford to lose that. So their lobby is very strong. I don't know what's going to happen. I do know that if I own the surgery center or if I'm managing my own surgery center and I'm an orthopedic surgeon and all we're doing is orthopedic surgery there and I can control the efficiencies of it, it becomes a white glove service for the patient. And so the patient, comes in, it comes out as a wonderful experience as opposed to going through a hospital system, trying to negotiate all that just to get the surgery done. So I think that within 5 years here, except for trauma, maybe complex spine revisions, tumors, and infection, everything is going to be in surgery centers, whether it's owned by a hospital or privately. That's going to be elective orthopedics for sure, is just going to be office based, diagnostic office based, and then your surgery center and physical therapy, that kind of thing, all vertically integrated in a private practice, which would be really great for the patients because the patients have a one stop shop and a very nice experience.
Yeah, I mean, and it's fascinating, but just to unpack that a little bit, like most of our viewers who are not doctors, their perspective are our patients. Their perspective is, Dr. Sanders tells me I need surgery. You tell me where to show up and I'll be there. They don't understand, like, oh, this is a hospital loan, this is a true ASC. I mean, Dr. Sanders, can you just explain a little bit, I guess, for our non-doc viewers, like what's that difference of a truly ortho-owned ASC where you're dialed in versus your hospital system where you're like, all right, let's just try and get people through today.
Yeah, well, in a way, it's kind of like the difference between a large chain where you go to eat. Let's say you go to I don't know what a large chain is, but like Chili's or something like that, right? Or you go to a local restaurant where the owner, is there to greet you and, make sure the quality of the food is perfect and all of that. It's just so the difference is a hospital has, they've got an emergency room, they've got, cardiac surgery, they have, you know, ENT, they have all sorts of different subspecialties. They're delivering babies, they've got sick people with strokes and then, right? So they have all these different things they're dealing with and they're trying to be, service the entire community. But and so even if they have a surgery center, so the two different things, right? So you can go to the hospital to get operated on, and you might do a total hip, and then the guy that follows you is delivering a baby or doing a sinus reconstruction or something, right? Or putting in cochlear implants. So it's all kind of a mix, right? And then they can also have a surgery center, which is an outpatient facility. It's a smaller building and and you don't stay in the hospital. So there's less risk of infections because you don't have hospital acquired infections. So an outpatient procedure in an outpatient facility is better than doing it initially in a hospital, although obviously the hospitals have improved their qualities. And so it just theoretically it's a better experience if you go into an outpatient facility. But again, a hospital and many surgery centers that are privately owned by surgery center companies also do a lot of different surgery in their surgery centers to support them. When you have large groups like Florida Orthopedic or Rothman or Panorama, and you have your own surgery center and you have enough surgeons, then you don't need to have other subspecialties there. So it just becomes a very unique experience because it's all orthopedic. The nurses only do orthopedics. All the equipment is there. And again, it's extremely efficient because it's just very focused, and that allows for increased efficiency. And then if the surgeons have ownership in it, whether they own the whole thing or they own it as a minority owner with a surgery center company, they can manage it and they can make sure that it's going to give the patient just a wonderful experience, right? And so that I see is just going to continue to increase across the United States. And I believe probably the patients will eventually then say, well, this place has a great reputation, but they won't even know necessarily the doctors, although they'll know that the doctors are good, but they know that the outcome from that facility is exceptional. And that's really kind of what we want. We're trying to make sure that the brand means something and that the quality is there no matter who takes care of you, that the people that we hire from the physicians down to the janitor and the staff in the operating room are all excellent and focused on high quality, efficient care so that the outcomes are excellent for the patients. That's what you want.
Do you have
Yeah.
any issue with insurances coming back and saying that surgery either needs to be performed at a hospital-based ASC or an outpatient ASC at all?
So now the problem for the hospitals are that the surgery that is at the insurance companies say that it's less expensive for them to go to an outpatient facility. They actually, in January, I won't mention the insurance companies' names, but several of our insurance companies have demanded, they've given us the CPT codes that require being done at a surgery center or they'll deny it. And it's an outpatient procedure already, but they're denying an outpatient procedure in a hospital outpatient facility that has to be at an ASC. So the hospitals in Florida are slow, at least on the West Coast where I work, have been slow to build surgery centers, freestanding surgery centers. Because if they're off campus, then they're not able to get hospital rates. So
We also
tug
experienced
of
that.
war, right. So that's a tug of war between the insurance companies and the hospitals. And we just work. We just try to take care of patients and provide quality care.
And not
So
stick
Dr.
them with a huge bill.
So Dr. Sanders, you're clearly a very intelligent man when it comes to practice management. So I'm going to give you a tough issue that I don't know the answer for yet, but I want to know if you know the answer. What do we do with insurance companies like Medicaid who don't reimburse implants, but now are magically saying, hey, we want you to be done at an ASC. That's cheaper for us. What's the answer to that question?
Think that you have to just work through it, right? Obviously, you can't go bankrupt, but there are ways to blend rates. And when you look at your overall commitment to patients, I think that it can be worked out. It has to be balanced. Obviously, if you can't do uninsured and underinsured patients exclusively in a facility like that, it becomes a problem. But clearly, if patients have a requirement, you can work. The other problem, at least in Florida, most of the Medicaid is HMO, and the HMOs do get a different kind of funding. Now, this is a whole different problem, and I don't want to get into this in the podcast, but the Obamacare, the ACA, um, Affordable Care Act money is different than Medicare. So in Medicare, the government pays 50% and the state pays pays 50%, and it works out to about 80% is covered and 20% of the premium is from the patient. It might be 25, but I think it's 20. Whereas in the ACA, the Obamacare, it's 90% by the federal government and 10% by the state for the Medicaid. And the problem for that is that the big beautiful bill wants to reduce it to save money and bring it back to 50% federal. So who's going to make up the 40%? Not the states. And so that means that if they don't support that, then the patient has to pay that. And most of those patients, and a lot of them, it turns out to be are small business owners that are just trying to give their employees health care. They can't afford that jump in rates, and that's what's going on. Yesterday, apparently, the Congress was unable to reach a decision about this, so it's going to become an affordability crisis because if the Obamacare HMOs cannot support this, and the patient and the small businesses are required to pay the premium, they're just going to do without, which is going to create a significant number of unfunded patients. And I have lived through that where patients just can't go to the doctor. They can't get care. They live in the emergency room only at the very end of they're crippled and then they come in and then it becomes very difficult to take care of them. So I'm hoping that they resolve some of this because I don't care where they go, they need to be treated. And not having healthcare in the United States for people who are sick is just really not appropriate for the richest country in the world, honestly. So that's just
Yeah,
my
and I completely agree. So, we were talking earlier about how, you are a trauma surgeon. Can you tell the listeners a little bit about your training, maybe starting with residency in joint disease and kind of what were some of the key mentors or some of the key moments that kind of guided your career into special
sure.
subspecialty?
So I went to joint diseases, which in New York City there are two or there were back then two very large orthopedic hospitals. One was special surgery, the other one was the Hospital for Joint Diseases. And the Hospital for Joint Disease eventually got bought by NYU because it was down the street. But it's still an independent orthopedic. And I think the entire orthopedic department of NYU, I might be wrong, is all at joint diseases now. So I was always trained in a situation where I was just engulfed in orthopedics. But during my residency, one of my mentors, my first mentor was a gentleman named Howard Rosen. He had the Salvador Dali mustache, and he brought AO to America. He had to buy the tackle box and bring it back from Switzerland. And I spent a lot of time with him. I don't know. I just like working with my hands, and I like building and carpentry and all that stuff. And trauma reconstruction, especially plates and screws, is just a natural for me. And so he was very instrumental in helping me in my career. I was actually at some point I toyed with doing a spine fellowship, and my chairman, who was Viktor Frankl at the time, one of his biomechanical folks was a guy named Dan Spengler, who became the chairman at Vanderbilt. So back then there were no matches for fellowships. You kind of called up and said, "Hey, I'd like to come spend time with you." And they'd say, "Sure." So I went down there to spend a year with Spengler doing spine, but he wanted somebody to take a call help with fracture care at Nashville General Hospital, which was kind of a community indigent hospital in Nashville, about 15 minutes from Vanderbilt. So I went down to Vanderbilt to do spine, and I ended up doing this stuff at Nashville General. And at some point, Spengler went on a long, I don't know, like a teaching lecture circuit for like 3 months. And I said, well, I'm not really interested in this. Let me spend some time with the trauma guy there. And they had just hired Swinkowski, who had come back from his fellowship. So I was Mark Swinkowski's first fellow, and spent the rest of the year with him and switched. I didn't do spine. I ended up doing trauma. And then I asked him, he asked me if I would stay to be a faculty member and be chief at Nashville General Hospital, which is a hospital, by the way, it was built in 1896. It doesn't
Yeah.
exist anymore. But I said, sure. So I was chief. I was also the only attending. It was great. But
It's good for call burden there.
yeah,
Great
well,
resume builder.
it was tremendous. Yeah, my wife wasn't too happy. I took call every day for 2.5 years. But one of my residents was Chip Rout. That was great. We had a really good
Yeah. I
experience
can
there.
I can only fathom what that would have been like to to instruct
Really
Dr.
amazing. Yeah, we can't get into the stories there, but it was a learning experience. And after that, we s- so anyway, so I keep digressing about all this, but I ended up, they had a AO resident course. The first AO resident course was in Jackson, Mississippi, and I went down there and gave a lecture and was fortunate enough to participate in that. And the faculty was just profound. It included Tony Russell, included Jeff Mass, and included David Helfett, and a whole bunch of other people that I got to meet. Howard Rosen was down there. And that kind of got me really involved in the AO. And so, in order to become chief of orthopedics at Nashville General, I told Spengler that I would do that for him if he let me go on an AO fellowship. So I went on AO fellowship, and most of the time was spent with Tom Rudy, who then is also a mentor of mine. For the folks that don't know, maybe he really developed all the surgical treatment for pilon fractures. Is what he's most famous for, and he is a master surgeon. He's a general surgeon. He's not an orthopedic surgeon, although he obviously was involved with the AO and is still peripherally involved with them. And I remember scrubbing with him one day, and the efficiency in that OR and core is just spectacular. And they have these rooms where they have an induction room and an extubation room, and these small little rooms as part of the main OR. And they have McKay tables. McKay tables have pedestals in the center of the room, and the patient gets put on a bed that's on a carriage, and they get induced, and they go into the room and they click it into the pedestal, and then the carriage comes off. Then they operate on the patient, and when they're done, they click the carriage in and put them in the extubation room. So the turnover is 10 minutes. You have time to either
Fascinating.
go to the bathroom, to have a cup of coffee, or dictate, but you can't do more than one of those. It's in the morning, this guy he did a thyroid resection, and I kid you not, there are probably 2 cc's of blood loss. It is just like amazing. Then he did a femoral nailing with, I don't know, he used this X fix as a just to hold it out to length for traction. Then we did a complex peel on, and it was really complex, absolutely beautiful. And then after that, he did esophageal resection with a gastric pull through. And we ate lunch, and it was 1:30. We're done. I can't even imagine that in the world. But and everything was. He was talking the whole time. It was snowing outside. They have these massive windows, and then windows in the hall across, so you can actually see the mountains with the snow, and it's just like, yeah, it was a it was a wonderful experience. After that 2.5 years, my wife said it was time to leave Nashville, and because of my connections, I got to meet Phil Spiegel as well, and Dr. Helfet was already in uh, uh, Tampa, and because Dr. Mass had left, I was able, through my mentors and my network, to be able to come to Tampa and work at Tampa. And I've been here ever since '87.
Nice. Where are you from originally?
New York City, Queens.
New York City. What's it like growing up in Queens to now living in Florida? I can imagine Queens is much different than it was when we grew up.
Yeah, it's not so different, but
It's expensive now, right?
yeah, well, it was, I lived in Jackson Heights, right on the edge of Corona, which was the hood. And so we were very poor, didn't have a car. I walked everywhere. I took the trains, the subways into the city, and I rode my bike. That was about it. And until I couldn't really afford to go to a college outside of the city, even a state school was too expensive for us. So I went to City College at Queens College, and I would take the bus there. I'd ride my bicycle to Flushing, and lived at home until I went to NYU. And the first year, I actually rode my bike from Queens over the 59th Street Bridge to get into New York, which is a really fast way to get into town, I have to say. Yeah, it was a whole different, back in the 70s, late 60s, 70s, there were not really very many well-off people, right? Everybody was happy, but, we were lower middle class, but, nobody really complained about it. Everybody I knew was in the same situation, and we were happy, and it was just a different time. Money wasn't as a big an object as it is now in this country, and so there was a lot of opportunity, and I was very fortunate. I got a free education. City College at that time was free, and I don't think I would be where I'm at today if I didn't have those opportunities made available to me. I was just very fortunate.
So why medicine? What made you wanna go to medical school?
It's a long story, but my grandfather was a physician in Germany, and so there was this medical background in my family. But my father really didn't like business. He didn't have very good experiences with business, and so my parents emigrated during the war to New York, and he ended up cutting paper for 30 years in an offset printing press, printing company. And he really didn't like labor unions, and he didn't like business. So I didn't have any experience with any of that stuff. I actually thought I'd become a history professor, but I started doing well in school, and I thought maybe I could get into med school. So I tried, and I got in. But just to be clear, I hated med school. I didn't really, I don't understand. This is my personality. I didn't like medicine. I didn't like walking the halls, standing by beds, going to the next bed, going to the next bed, making rounds endlessly. I thought maybe I'd like surgery, but all we did back then was run bowel, and that's just really not interesting to me. And at some point, they told me I had to do a rotation, a week rotation in a subspecialty in surgery. And I said, okay, well, I don't know, ophthalmology or something. And they said, well, the only thing that's open is orthopedics. And I said, okay, what is that? And they said, well, that's something to do with bones. And I hated medical school. I actually, the first 2 years, I just did the note. We had a note service, and I would study the notes, and then I'd come into the test. But I really didn't hang out in medical school. I was working full time with my uncle, who was an electrician down in Soho. We were doing construction and rebuilding all these old lofts and turning them into residences. And I was gonna go work with him. I was gonna actually quit medical school at some point. And so I go do this week at in orthopedics, which is something about bones. And I walked into the OR, and they were doing a hemiarthroplasty, I think. And there on the back table were all my uncle's tools. There was saws, there were drivers, And I'm serious. I said, wow, I can do this as a doctor? And they said, yeah, that's what we do. So that was it. I mean, honestly, that was it. And
Is
so,
so
That's awesome.
special, and the fact that now that you're such a profound surgeon, that story just is such a testament to who you are as a person, and you're just like, "Yeah, I could do this. This is easy."
yeah, right. I could, because if I couldn't do that, I'd be an electrician right now.
Oh, truly. I mean, Dr. Amendola always used to say in patients' room, we are truly the carpenters of the body. And I own that and I love that, to be honest with you. Because the reality is, I think with in our society with AI getting as popular as it is, I mean, we may become a society where trades are the only real jobs that actually exist. And when I think of medicine, we're the tradesmen of medicine.
The difference, of course, is with the tradesmen, if they make a mistake, they can throw it away and do it again, right? Maybe not charge you for it, but they can do it again. You have a problem with your car, you can junk the car. Yeah, you got one shot with a doc. I mean, I try to teach my fellows and my residents and med students, yeah, it's really hard to understand this, but a patient comes to see you and then they agree to go to sleep and let you operate on them. And the amount of trust that is required to accept that and hope that you're going to do the right thing for them so that when they wake up, you've solved their problem. That is just an immense responsibility. It's just until you really start working and see how hard it is to get a good result, sometimes with complicated problems, you cannot really understand the responsibility that people have entrusted in you. And, we're only human. All you can do is try your best, but you have to try your best. But if you try your best and it doesn't work, and you know, that's life, right? And so it's just a very, very demanding profession of all the trades. Let me put it to you that way.
Yeah, and so, I have my 66 Mustang that I work on for that very reason. Would you say, because I heard you allude to carpentry, I imagine you got a lathe or something in your garage, maybe.
Yeah,
Is that's kind of a
actually, I
similar reason?
don't have time for any of that stuff. I was so busy in my career, I never really.
Do you do any kind of woodworking or anything on the side when you
No,
get a
I just
second?
do all the stuff around the house, whatever needs to be done. But I mean, I'll do the carpentry around the house, the electric work around the house. I'll do projects. And my wife said, "Why don't you hire somebody?" And I said, "Why would I hire somebody if I can do it?"
Well, you truly can do it. Kinley, funny story. The other day I went over to Kinley's house for a little party. And Kinley, do you want to tell the story actually when I saw your
Was
mailbox?
Was this my mailbox? So in hindsight, we were dealing with some other home projects, but my mailbox was like he said, "Kinley, you can't work in orthopedics with a crooked mailbox. You need to fix that." So my husband the next day, who's also very handy, went out and rebuilt a new mailbox for me. But the funnier part is I decided I was gonna repaint my whole porch a couple weekends ago. Well, my banister was a little shaky, and so I was like, I'll just throw a lag screw in this. It'll be fine. And sure enough, it was perfectly fine. And I went to Dr. Bookchan and I was like, you would be so proud of me. I got my husband's drill out and I put a lag screw in my banister and it's now very sturdy.
Yeah, it's called basics. Yeah.
So Dr. Sanders,
Home Depot, I get lost in Home Depot for hours. At some point, my wife has to call and say, "Can you come home now? You've been out too long." So,
I firmly believe that the man that dies having accumulated the most tools wins. And that is
tool.
the only thing that we will be judged on.
I'm glad I have headphones in because my husband does not need to hear that.
So, Dr. Sanders, I want to touch on a point you just made because it's an important point, and I think it will help a lot of younger docs who don't get the benefit of getting trained by you directly. So, something that a lot of people my age, a lot of surgeons my age will say is when they come out of training, they're having a hard time dealing with what you just said, right? The immense amount of responsibility you take when you take someone's life into your, well, not life, but their body into your hands. Um, and for you, a man like you, I can imagine your surgical ability is in many ways probably automatic because you've been doing this as long as you can. But for a younger doc who doesn't have that automation, you have complications. This is how you learn. This is how you grow, and you want what's best for your patient. But inevitably, you have complications. So, what is it like, and what was your process of learning how to accept that responsibility, live with the complications, but to not kill yourself over them, but allow yourself to get better? Like, what was that like for you?
When you have a complication the first time, it's very painful because you don't know how to react to it. I would say the vast, overwhelming majority of people are not sloppy. It just, they get a complication for whatever it is in surgery, right? And I think one of the things you have to do is you have to own it. You have to tell the patient that you have the complication. Obviously, in the beginning, before you do the surgery, you have to sit down with the patient, really explain. They don't hear anything, but you have to tell it to them so you know you spoke to them about it. Then you have the complication. You have to um, accept it, tell the patient, and then the patient is then at a loss, right? Because the patient doesn't know what to do. The patient is looking to you for guidance. So if there is a complication, and you're honest about it, then either you are able to fix it for the patient, or you need to tell the patient, I'm going to send you to somebody who I know who can fix this for you because this is a problem. It's fixable. I don't have that skill set. There are surgeons that tend to either don't say there's a complication if they can kind of get away with it, or they don't, or they just abandon the patient. They say, well, that's the way it is, that's your body, blah, blah, blah. You had a bad fracture, you had this is the best I could do. And then the patient is stuck with it and doesn't understand that either there is something they could do or there's somebody who could help them. And so I would just say, be a patient advocate and go through that. Now, if it's a bad complication, you're going to get sued. And if you get sued the first time, it is for everybody. I've gotten sued once in my life, and it is a devastating personal affront to who you are as a physician because you don't understand the approach that the lawyer has. The lawyer wants to paint you as a sleazebag, not caring individual who's just in it for the money. Now, the personal injury attorney is just in it for the money because they have to make money. That's the only way they can make money. And so they start disparaging you as a human being, as a person, as a surgeon. It is so painful that everybody that goes through that it's just awful. When you get through that on the other end, and most of the times you actually win, or sometimes the insurance company just decides to settle for you because they don't want to deal with it. It's cheaper for them to settle in mediation than to go to trial. Either way, you begin to realize that it's, for the most part, just nonsense, and they're just trying to make money. So after that first assault on your person, you learn how to compartmentalize that. And you obviously are, when you do surgery, you want to have a great outcome. You don't want to have any complications. If you're somebody who cares and pays attention, you're not going to have complications very often. But if you don't have complications, then you're just not operating very much. Everybody who operates is going to have something go wrong at a certain point. That's the beauty of doing a fellowship. You're focused on what you're good at and you do what you're good at. So your complication rate is going to go way down, but it won't go to zero. But then you'll know how to manage them. You'll know how to talk to your patients. You'll understand what's going on. And if you do get sued, you're not going to take it personally, right? There are people though that get sued, just frequently, and either they don't care or they're a terrible surgeon or they shouldn't be doing what they're doing, right? Those are outliers. But for the vast majority of surgeons, you occasionally will get sued because you occasionally will have a complication, which is the natural state of affairs, and you can't take it personally. But the most important thing is that when it happens, that you're honest about it, that you sit down with the patients, and that you, in fact, are an advocate for the patient and either solve it for them or find somebody that can solve the problem for them if that's possible.
Yeah.
I think that's a really important point that, surgery is such a fine-tuned, oiled, you do the same procedure 100 million times, but the determining factor is that we're operating on individuals, and individuals have different issues and different things like that. And so I think the complications, it's not that you're a bad surgeon, it's just things happen and you're still human after all.
Right. But you can also carry the patient all the way through their experience, and as long as you're with them through that, they're very grateful because, again, in the beginning, they don't know who to find, and if something goes wrong and you abandon them, they don't know where to go, and it's just a real problem in the system, right? So,
Yeah.
anyway, that's what I would tell people.
Well, Dr. Sanders, I mean, just reflecting back on the short hour we've had together, it's very clear to me that the amount of knowledge that you've accumulated is great, but it's also, I would say, almost delicate in the way that you're constantly looking to put patients first. Because I agree with you completely. Life gets complicated, money gets involved, people start making some decisions that probably aren't ideal. But I think when you allow that patient guidance and just putting yourself in their shoes to be the true north that your compass flows to me, I think it's profound the number of things you've been able to do that are so amazingly successful, but keeping the patient at the center. So I guess I would just say, props. And I guess I wish I could have been your mentee at one point. Uh, so now, we can't keep you much longer. We've already talked, or we've had an awesome conversation, but I do want to ask the most important question. So the most important question for us is going to be who you want us to interview next and who you think that would be a good person.
I think you maybe, try to get